Genito Pelvic Pain Penetration Disorder, GPPPD. What does this mean? Dyspareunia? Yes. No. Yes. It includes dyspareunia. We'll start with the higher. Chronic pelvic pain, a broad terminology of main group of disorders, chronic pelvic pain. Then in that subgroup, genitopelvic pain penetration disorder. Okay. In that it includes dyspareunia, vaginismus, vulvodynia, vestibulodynia, everything. So all this group of symptoms is called as genitopelvic pain penetration disorder. Okay. So what is it? We'll see. Persistent or recurrent difficulty for vaginal intercourse, vaginal penetration during sexual intercourse. Persistent or recurrent difficulty in it. Marked fear, anxiety, marked vulvovaginal pain during vaginal penetration during intercourse. For that matter, anything, penetration. Then marked tensioning, anxiety, fear, marked tensioning of the outer one third of the pelvic floor muscle, vagina, spasm of it, that is vaginismus. It can be vaginismus, spasm of the outer muscles of vagina, it can be vulvovaginal pain, or it can be actual dyspareunia, physical, or some cause related to it, that is marked persistent or recurrent difficulties for the vaginal penetration during intercourse, or for that matter any intercourse. Means it can be insertion of a tampon, menstrual cup, finger, or examination, anything, and it should be at least for the duration of 6 months. Then it is labeled as genitopelvic pain penetration disorder. Okay, so this is now there are various conditions which are associated with this. It can be an independent and it has its own specific causes, and there are various other health conditions which can be related to genitopelvic pain penetration disorder. Conditions like endometriosis, interstitial cystitis, irritable bowel syndrome, endometriosis, fibromyalgia, uterine fibroids, pelvic floor dysfunction, psychological causes. There are various innumerable exhaustive lists which can be associated with this condition. Okay, so what are the specific conditions which are related to GPPPD? Which is a specific what conditions can lead to this pelvic pain penetration disorder? So conditions like there are various numerous conditions like infection. It can be vaginitis, vaginosis. It can be HPV infection, herpes, other vaginal infections, STDs can lead to this site of pain. It can be inflammation, chronic neurological diseases, chronic neuroproliferative factor. When there is increased nociception of the nerves, hypersensitivity of that area, which was previously not there, and during the time it has been increased. Okay, then it can be chronic use of tampon, menstrual cup, recurrent UTI. Also, it can lead to history of riding of bicycle. Chronic bicycle riders may have this pain, or because of the pain they cannot ride the bicycle. Both the ways it can be there. Then it can be because of low use of OC pills, menopausal, low libido can lead to this sort of pain. This pain can lead to a cause of low libido, low testosterone. Then apart from this, overactive pelvic floor dysfunction, it can be hypertonicity or overactive pelvic floor, which may lead to genitopelvic pain penetration disorders. So various causes can be there which can lead to this sort of disorders pain. It can be just outer, it can be localized vulvovagina, vulvodynia, vestibulodynia, or it can be physical, or it can be superficial, it can be deep dyspareunia. Prolapse may be of one of the cause because of the pain. Prolapse may also lead to pain. So these are the causes of the we can wear. Both superficial, both deep. It can be provoked, unprovoked, or generalized, localized, everything. Now, how you assess them? The most difficult part, or the most important and the less focused part. How you assess this pain? It has a 6 month duration. We know what it is. It is also various other health conditions or other pelvic floor conditions, and it has specific its causes also. Now, how you assess? It's most frustrating both for the patient and the treating doctor, the assessment, because usually when the patient comes to you, she has already visited 2 to 3, and she has a bundle of records for her to show, and again to repeat the same story of the pain, and she is even doubtful whether it will be cured or not be cured. Okay, so it's very frustrating for both. So whenever you start the history or you take the history, remember, most important, it should be a couple history. When you're dealing with genitopelvic pain penetration disorder, it should be a couple history. Okay, both the partners should be involved actively in the history process. Then during history or at the end of history, first, when you meet the patient, most important for the patient, 50% here the patient getting cured by is validation of pain. Yes, you have to give that the patient that validation. Yes, her pain is real. Pain is for real. You many doctors you might visited, or usually it is has some or other times even the relatives or the it has been said that it's all in her head. It's not in her head, it is in her the pelvis. We have to find the cause. So it's both frustrating for the patient and the doctor. So you need to give the most important validation to the patient. Yes, the pain is real, and you try to find out the probable etiology. Yes, the exhaustive list of the diagnosis, the exhaustive history has to be taken, the exhaustive workup has to be done, and with that is the you get only the probable diagnosis. We never in a GPPD or chronic pelvic pain, we never have a definitive diagnosis. It's always a probable diagnosis whenever possible, because in almost 15 to 20% of the cases, there is no identifiable cause identified for the pain. So whenever possible, after the exhaustive history and the examination and the evaluation part, probable diagnosis can be given to the patient whenever possible. So in this, you need to take the couple as a whole actively involved and give the validation to the patient. Yes, the pain is real. It's not in her head. And then you start. So during our normal history, whatever you take, evaluate. The specific to this is when you take the history, important is that you try to learn the anatomy from the patient. Yes, means ask the patient what is her, according to her, what is the descriptive of the anatomy, what she imagines, what is the anatomy, what she perceives it as her anatomy. Okay, that is very important. You might have dealing with such cases, so you know the patient have the different perseverance of the, and because of that it's pain. Means actually the pain is real, but because of all it's because not the pain is in her head, but the anatomy what she senses, it's that. So you need to learn the anatomy from the patient, what she perceives. If then the other myths, if she's having or she has some myth regarding to any of the practices she follows, and she has a myth to her the female genital area, she has any myth, then you need to ask and clear it off, because many patients carry many sorts of myths and they just focus to it, and that also one of the reason they are not able to overcome the pain. Okay, so when you do the history, so try to learn the anatomy of the patient, what on the patient perceive, how the patient learn the anatomy, the which patient perceives herself. Okay, so this is in the basically the history part. Then by the end of history, you just give the validation to the patient. Then you start for the examination or the assessment. Before that, in the history specific to the pain, now we focus on the pain. We go by three ways. Pain, it can be an acquired or it can be a lifelong pain. Now, what is an acquired? Initially, it was there was no pain, and after some event or any precipitating or anything, she has developed it later. Lifelong, from the age of teenager or since usually after delivery, chronically she's having the pain. Now, in this, just give an example, as a female comes to the OPD previous to vaginal deliveries, she comes with a complaint of pelvic pain. Now, she has been examined. We take the history, we go for the examination, and we have seen many this cases such. What happened is that when the examination is done, the patient screams a lot when for the perspectival examination. She is coming with the pain, and usually it is said that uh, दो बार vaginal delivery हो चुकी है, why you're fearing so much is there, let me check, without check how we come to know. No, it doesn't mean that she has been vaginal delivery, so you can insert a sim speculum or she will have not pain. It usually, I'll go back. Residents of when we are taught, it's like newly married or with the newly married, they have the fear, anxiety for going for the per speculum and per vehicle, so they can somewhat shy or resist, or they may have pain. No, but that's not the case. Any patient with chronic pelvic pain, usually you don't do any examination in the first visit, because the history itself is very exhaustive. You have to build a trust relationship with the patient. You have to ask many various detail about it, and just give her time to relax. So usually we don't do. And per speculum is the very last thing to be performed on the patient which complaints come with a chronic pelvic pain. It's the very last thing to do when she is comfortable. So this is the very misconception. What I said, seen such practical scenarios. The patient has been vaginal labor, comes to the OPD, and you might also encounter it many times in our residency also days. We see and we examine and say, what's the problem? Already you have done vaginal just a perspective, how we come to know the diagnosis. She has come with you with a pain. It might be vaginismus, it might be vulvodynia, it might be the outer side. So first speculum is very dangerous for such patients to be performed. So in the first visit, never try to avoid the examination if possible. And even if not the first speculum, never in the first visit. So this is the something basic. Coming back to the history, what I was saying, acquired or lifelong. So it may be that previously she may not have the pain, and now she has developed the pain. Okay, this may be the thing. Then it may be situational and generalized. Specific situations the patients have the pain. Just for an example, vaginismus. It's the spasm, tensing of the pelvic floor, overactive pelvic floor, spasm of the outer vagina, voluntary or voluntary usually, during fear or even imagining that something going to penetrate, there is a spasm of this. Now it can be situational. Now in this, again, what I have said previously, the learn the anatomy from the patient perspective, or the patient what she perceive as anatomy. Now, what is there in vaginismus cases? I will discuss example. When you teach her how to get rid of the vaginismus, just vaginal dilators by candles or dilators, fingers, various methods. When we teach her the to overcome the vaginismus fear, she's able to. She's okay. She got relaxed while doing all this thing. But when it comes to the sexual activity, she is not able for the again. She develops or she has the vaginismus and she is responding to you all the therapies, but she's not responding to it. Now here comes the role of anatomy. She's something perceives something else. There may be some myth or something related to it. So the history is very important. The couple, you need to evaluate both as a couple. It's not just only the patient evaluation, it's a couple evaluation for genitopelvic pain penetration disorder. And then again, you need to ask what they perceive as anatomy. Second important point. Third, the myth or something they have in the mind. So just I gave the examples in the treatment of vaginismus, patient responds to everything, but again when she go back to this, then she has a pain. There's something wrong or something they think or imagine as that this will be the fearful or some idea, and that will lead to development of pain or vaginismus. So this acquired, lifelong, situational, generalized. Then the third comes in evaluation, provoked, unprovoked, or spontaneous, because something imagination, or it may be provoked or it may be unprovoked. It can be generalized also, it can be localized, restricted to posterior vestibule, usually in case of overactive pelvic floor hypertonicity, overactive pelvic floor, there is usually pain in that posterior part of the vestibule. Where it is hormonally induced, it can be involved in the whole of the pelvis. Same is with the nerve neuroproliferative nociception. It can be generalized to the whole of the pelvis, or it can be specific to any one area of the vestibule. So this can be done with the pain. Now, then comes in the next point in the history is the characterization of the pain. Usually ask what is a sharp, blunt, how she feels, any trigger factors, any trigger points, any factors which help in the resolution of the pain, or anything which related to diet activity which increases the pain. Yes, diet is also very important. Patients themselves say when I eat this, uh, my pain aggravates. So you need to important ask specifically in the history. So these are the important point in the history. Okay, so here comes, then comes pain. You have to ask the relation of pain with urinary, bowel complaints, and the sexual complaints. Yes. Isn't the pain having any relation with the urinary complaints? Is the pain having any relation with the bowel movements? Pain related to the sexual relationships. Okay, this need to be evaluated. Now, urogynecology, everything is about good history, and the good history. So, even if the patient does not give, first you ask a very good history, derive a very good history, and how to derive a history in a urogynecology. It's always a leading question. Patient may not correlate or they may over correlate the things with that. So, listen to the patient, but keep your bunch of tests also together with you so that you can ask the leading question and get to your probable diagnosis whenever possible. So in this one, what thing can help is the questionnaire again. So in questionnaire, we have one International Pain Society question. They have a very exhaustive, good whole range of questionnaires there, include, exclude each point, each system which can be the because of the which pain can be involved. Okay, I'll share that questionnaire link in the description below. So that is one of the questionnaire which is to be included in your genitopelvic pain penetration disorder assessment evaluation. So here comes the history. Now in the next comes the examination. As all you first do the general systemic examination, then very specific come to the local examination, inspection, you see any local scarring, condition of the tissue, then you do the inspection of the palpation, you see it. Now usually what we do when we do the per speculum, per PV or pop cure, anything, we focus on the local genital areas, we examine it, but not in this case. In GPPPD, you focus on the genital areas and with the patient face. You need to see the expression, you need to see the tenderness, you need to evaluate for the tenderness, you need to see the facial expressions, you need to see the face. So remember, when you examine the patient, just don't focus on the genitalia. See when you're whatever you're feeling, touching or palpating, how is the patient reaction. So by that reaction, you have to see the face. So remember this thing very important in the examination when you ever do. Okay, so this is an examination. So you how you do start with the examination: q-tip, wet swab, cotton swab test, no, mapping of the pain, as we do the fibron mapping by the MRI or ultrasound. So here do you the manual, you do the mapping of the pain, and by obviously mapping you can do by seeing the face of the patient, by asking, but always looking at the face also. So you do the mapping of the with a q-tip or swab, cotton swab test, into the mapping of the pain, which area is affected. Then you look for the vaginal pH. Yes, very important. Normal vaginal pH is acidic. You see for the acid pH of the vagina. Then you see for the evaluation of pelvic floor muscles. Yes, it's overactive, it's underactive, it's normal, it's situational. It can be both the component of underactive and overactive pelvic floor can be present in a single patient. Sometimes she may demonstrate you, or you may notice the overactive pelvic floor, but in the history when you have taken it, there may be symptoms of showing that she has an underactive pelvic floor. Some symptoms are correlating with underactive, and you have examined and you are seeing the overactive pelvic floor. So even the one examination is not sufficient. Whenever suppose for example you do the any per vaginal examination for suppose fibroid mass, so it will be the same at least in certain few months. It will not suddenly increase. But related to pain, you have to do the repeat examination to exactly arrive at the diagnosis. So first is very gentle validation, trust of the patient, counsel her, and just do with the just local examination, make comfortable her with examination point of view. Examination should not lead to the anxiety or fear of the pain, should not evaluate. She should be relaxed, so relaxed that by examination her cause of pain may be read, maybe find out. Okay, so in pain while you do the examination, that is very important. So even the that changes, so history is important. Many patients come with the examination, we find the overactive, but in symptom it's underactive. So both can be correlated. The situational, it may differs in both situation you examine. So repeat examination, or by changing the position of the patient in the different positions to examine, by conditions different is to examine, you can know the symptom of the patient. So in the examination, just to shorten, mapping of the pain, vaginal pH is important, and pelvic floor. Other all it's like you see the scar, you see any myofascial band, any trigger point outside, inside, near the ischial spine. There may be tenderness, lever ani whole muscle. There is a very systemic pelvic examination. I think I've shared in one of previous video, or we may do a detail in this evaluation how to assess the pelvic floor. There is a very clockwise, anti-clockwise examination fingers to see the obturator, internus muscles, which pubococcygis, which muscles are involved, which muscles are tender, which muscles are in spasm. Also, okay. So this is was very short, comprehensive, very short about genitopelvic pain penetration disorder, which includes dyspareunia, vaginismus, vulvodynia, vestibulodynia, and it means a one of the subset of the huge term which is chronic pelvic pain. So chronic genitopelvic pain penetration disorder is one of the cause for chronic pelvic pain. There are various other causes and conditions, it may be associated, it may be single. So hope you found this video helpful. If yes, then please do like, share, and subscribe. Thank you.